All right, welcome everyone. So, let's talk about low T. We live in a world that's just flooded with ads for clinics and all sorts of confusing information. So how do you, as a medical trainee, cut through all that noise and diagnose true male hypogonadism? Well, that's exactly what we're going to do here. This is your essential, no-fluff clinical guide, perfect for your rotations and, of course, for your exams.
So let's just dive right in. I mean, you've all seen them, right? The commercials for low T that promise to fix, well, pretty much everything, from being tired to just being in a bad mood. But our job as clinicians is to separate that marketing hype from the actual medical reality. So the big question is, when does a patient's complaint really point to a true hormonal deficiency? That's the critical question we're going to tackle today.
And here's how we're going to do it. We've broken this down into 5 really logical steps. First, we've got to master the normal system, how it's supposed to work. Then we'll explore what happens when it fails. After that, we'll look at what the patient actually looks like in your clinic and then walk through the exact diagnostic steps you need to take. And finally, we'll cover treatment and, maybe most importantly, the critical safety checks you just can't afford to miss. So, let's get started.
Okay, first things first. Before you can ever diagnose a problem, you have to absolutely master the normal system. Seriously, understanding the really elegant machinery of the male reproductive axis is the foundation for literally everything else that follows.
What's so incredible here is just how beautifully balanced this whole system is. I mean, think of it like a really precise chain of command. You've got the hypothalamus, that's the general, sending out orders in the form of GnRH. The pituitary, kind of like the field officer, gets those orders and releases LH and FSH. LH then tells the testicular Leydig cells to produce testosterone, while FSH gets the Sertoli cells working on sperm production. But here's the genius part. Testosterone itself reports back up the chain to the brain, telling it to ease up a bit. It is a perfect self-regulating negative feedback loop.
So what happens when this carefully balanced system breaks down? Well, this brings us right to the core concept of hypogonadism. See, the failure can happen in one of 2 fundamental places, and knowing the difference between those two, that's the key to everything.
Let's just lock in a really solid definition right now. Clinically, hypogonadism isn't just about a low testosterone number on a lab report. It's really the failure of the testes to perform their 2 main jobs. 1, producing enough testosterone, and 2, producing a normal number of sperm. Both of those parts are absolutely essential to the diagnosis.
And this slide right here, this just brilliantly illustrates the central distinction you have to grasp. Is the problem primary or is it secondary? In primary hypogonadism, the testes themselves have failed. The factory is broken. The brain is sending the signal, but nothing's happening on the factory floor. In secondary, the testes are actually fine, but the problem is upstream. The brain isn't sending the signal in the first place. This one distinction is going to dictate your entire workup.
So we've got the pathophysiology down. Now let's translate that into the real world. What does this patient actually look like? What are the signs and symptoms we need to have on our radar when we're in the clinic? Okay, this is a really critical distinction. You have got to be able to separate the specific symptoms from the non-specific ones. The specific ones, things like decreased libido, gynecomastia, or infertility, those are your red flags. But the non-specific ones? Low energy, poor concentration. I mean, come on, that could be anything from depression to just having a bad week. And this is precisely why we don't just go ordering a testosterone level on every single patient who says they're tired.
All right, so you've got a patient, they've got specific symptoms, and you have a high clinical suspicion. How do you actually prove it? This section is going to give you a clear, actionable algorithm for your workup. No guessing.
I really want to pause on this quote because it's a huge clinical pearl. Honestly, if you take only one thing away from this section, let it be this. Testing men who only have vague symptoms like, "I'm tired," leads to overdiagnosis and, frankly, potential harm. Our investigation has to be targeted.
So here it is, your 4-step pathway, made simple. Step 1, an 8 a.m. fasting total testosterone. It has to be in the morning because of the diurnal rhythm, don't forget that. Now, if it comes back low, do not jump to treatment. Step 2, you must repeat it to confirm. Lab variability is a real thing. It's only after you have 2 confirmed low levels that you can move to step 3, which is measuring the serum LH and FSH. That's the test that's going to help you figure out why the testosterone is low.
And this is how you put all the pieces together. It's actually pretty simple. If the testosterone is low, but the LH is high, boom, you know it's primary hypogonadism. The pituitary is screaming for testosterone, but the testes can't respond. Now on the flip side, if the testosterone is low and the LH is also low, or maybe just inappropriately normal, that's secondary. The testes are ready to work, but the pituitary isn't giving the order. See? This one simple interpretation tells you exactly where the problem is.
So, you've made the diagnosis. Now what? Well, this final part of our explainer is going to cover the goals of therapy and, most importantly, the situations where treatment could actually be harmful.
When it comes to treatment, listen, there's no single best option. They all have trade-offs. Injections are cheap, but they can cause these peaks and troughs, mood and energy swings. Gels give you stable levels, but there's a real risk of transferring the hormone to others. And pellets, there's long-lasting, but they require a minor procedure. The right choice really just comes down to a good conversation and shared decision-making with your patient.
Okay, this slide is absolutely critical. Knowing when not to treat is every bit as important as knowing how to treat. And the number one takeaway here: if your patient is actively planning for fertility, do not prescribe testosterone. It basically acts as a contraceptive by shutting down sperm production. This is a hard stop, an absolute contraindication. And the other points on this list, that's your essential pre-flight safety check before you even think about writing that prescription.
And let's end the treatment section by circling all the way back to our first point. For men who do not have a confirmed biochemical deficiency, giving them testosterone isn't helpful, and in fact, it can be actively harmful. This just reinforces why our diagnostic criteria have to be so strict. We're here to treat a disease, not a lifestyle complaint.
And we'll just leave you with this final thought. Following the algorithm and correcting a lab value, that's the science of it. But managing your patient's expectations, monitoring for side effects, and addressing the root causes of their problem like obesity or sleep apnea, that's the art of medicine. And mastering that art is the real next step on your journey to becoming a truly great clinician.